This is Dr. Andrew Young over at St. John's, and we're going to step back and talk about medical management of patients undergoing elective hip and knee replacement, specifically how we manage the medications for patients who have inflammatory arthritis, psoriatic arthritis, or rheumatoid arthritis. Okay, again, these patients are on medications, how we manage these medications, and the guidelines prior to joint replacement. Managing these is one of the most complex and controversial issues related to joint replacement because patients with rheumatoid disease and psoriatic arthritis and inflammatory arthritis are often on very strong medications. And these medications potentially and theoretically could affect the outcome of joint replacement. The problem is there are no clear studies, there are no clear guidelines. And so every 5 years, the American College of Rheumatology and the American Association of Hip and Knee Surgeons come together to form a panel to create guidelines on how to best manage rheumatology medications. So they first came out in 2017, and then they just updated their guidelines in 2022. So the American College of Rheumatology and Orthopedics, the American Association of Hip and Knee Surgeons come together to put together a guideline for the perioperative management of anti-rheumatic medications for patients about to get a joint replacement. So why is this important? Why is this even an issue? The first thing is many patients that require joint replacement have underlying rheumatoid disease. And because of that, they are at an increased risk of a postoperative infection for two main reasons. One, the rheumatoid disease itself affects the immune system. It's an autoimmune disease. It's an inflammatory disease. And this by itself increases the risk of an infection after surgery. Secondly, many of these patients take medications, anti-rheumatic medications that modulate the immune system, and that may further increase the risk of a postoperative infection. So the risk of infection is intrinsically increased because of the rheumatoid disease itself, and then potentially increased further because of medications that change or modify the immune system. And so what we're trying to do in surgeons and what rheumatologists are trying to do and help us manage these patients is balance these risks, and specifically the risk of a disease flare-up if the medicine is withheld versus the potential risk of infection if they are continued. So whether to stop the medications or whether to continue medications. And there's no easy answers because there's a flare-up on one side and a potentially increase of risk of infection on the other side. So how do we manage this? How do we balance these risks? And again, there is no clear answer. This video is not here for treatment mandates. It's just so that you have an understanding of how your rheumatologist and how your surgeon are thinking about these issues and these risks. And so, let's turn to the guidelines. Now, before we look closely, we have to put the strength of these guidelines in context. Again, there is not a lot of data. There are not many studies that actually look at the withholding or the continuation of medications in the setting of joint replacement. And so this panel looks at a limited number of studies and tries, using first principles and consensus, to build a set of recommendations that can help patients and rheumatologists and orthopedic surgeons. And so they're reviewing currently available studies and medications, as well as patient concerns, and putting this together. And they accept that these things change, and that's why they review the data every few years. This is their most recent set of recommendations. I'm going to go through three separate tables. One, the DMARDs, or the disease-modifying agents. Two, the biologics. And three, the new class called the JAK inhibitors. And basically, you don't have to look at this table, but just see if you can find the medicine that you're on. So if you're on a disease-modifying medication, this is often the first line: methotrexate, sulfasalazine, hydroxychloroquine, Arava, doxycycline, or Otezla. These types of medications, you don't have to stop. So this is a newer guideline that we're understanding. You don't have to stop. You can continue these medications. So DMARDs, methotrexate, any of these, you may continue as a guideline as of 2022. The next class of medications are called the biologics, and this has probably been the most important recent advance in the management of rheumatoid arthritis and inflammatory arthritis. These really have been game changers for patients suffering with severe arthritis. they're stronger medications, and so they have to be managed a little bit differently in the setting of surgery. And again, these are all just conditional recommendations. These are not treatment mandates. And if the risk of infection is greater than the risk of flare-up, so again, this is something to discuss with your surgeon and your rheumatologist, then the schedule for holding these medicines is based on the dosing interval. So each of these medications is different. For example, if you look at Remicade, it's every 4 or 6 weeks. If you look at something like Rituxan, here it's every 6 months. And then if you look at something down here, it's every 8 weeks. So each of these has a different dosing interval. And the recommendation, if the medication can be held, is that it is done a week after your next planned dose. So again, see if your medicine is on here, Humira, just freeze the video, Humira, Enbrel, Rituxan, Kineret. See what the dosing interval is, and then you can see the surgery is done 1 week after your next planned dose. The third class of medications are an important update to the 2022 guidelines. These just came out in the past few years. These are the JAK inhibitors. These are given daily. And then the dosing regimen, if they can come off, is relatively straightforward. You just hold them all for 4 days. So see if you have one of these. And you just hold for 4 days. So again, the panel is not making treatment mandates. They are coming up with recommendations based on the best available information that they have, based on consensus opinion on first principles between surgeons and rheumatologists working in the best interest of the patient. Okay, so the first set are which ones you can continue. You can continue DMARDs, and you can also continue steroids. And the idea with steroids is steroids can be continued rather than being stopped and requiring a supraphysiologic stress dose perioperatively. So steroids and DMARDs have been simplified with ongoing continuation. The ones to stop are the biologics and the JAK inhibitors. The JAK inhibitors can be stopped at 4 days. Those are relatively straightforward. The biologics, again, plan for surgery 1 week after the next dose is due. Again, this is all conditional. This is in discussion with your rheumatologist and your surgeon. If it appears that the risk of infection is greater than the risk of a flare-up. Okay, and again, let's look at the chart. This chart of biologics is very busy, but maybe you can find your medications, pause, figure out what your dosing interval, and you can see that the surgery should be planned 1 week after the next planned dose. So the first set of recommendations about which medications to continue, and those were the DMARDs. And then the next set, which ones to stop. Those are the JAK inhibitors and the biologics, if it was all possible. And then the third question that the panel tried to ask is, when should the medication be resumed? And the general guideline is, if the medication is stopped, it can be resumed about 14 days after surgery, once it's clear that there's healing of the surgical site without evidence of infection. So first is when it can be continued, second is when it should be paused, and this last set of recommendations is when it can be resumed. And that's about 14 days, 2 weeks after surgery if there's no evidence of infection. So to wrap this up, remember, these are not treatment recommendations. They are not treatment mandates. They are just guidelines. And these consensus guidelines have been developed by a panel of well-meaning rheumatologists and surgeons. Remember, there's a limitation of available data. Currently, there are no strong studies that can provide definitive recommendations. Everything is based off first principles and what data is actually available. Secondly, we know every patient is different. The purpose of this guideline is to provide information so that the shared decision-making process, this is so important, the shared decision-making process between patient and physician is done in a more informed fashion. So again, wrapping up, how we currently are looking at the management of anti-rheumatic medications for patients undergoing elective total hip and total knee replacement. You can find that article in the Journal of Arthroplasty or the American College of Rheumatology. Go back, pause, screenshot, figure out where you are, and then you can use that to guide the conversation with your rheumatologist and surgeon. Thank you very much.